So we're going to talk about some of the changes that's going on. I've given this speech 5 times, and every time I give it, I change it, because there's more stuff coming out. In fact, this morning there was a thing I read that they're pretty much sure all the healthcare premiums are going up next year. Not only probably for us, but for everybody, and for the exchange plans. We're going to have major issues coming along that way. One of the things I want to explain to you is why do I get to tell you what I think? You know, why do I get this place up here? And the truth is, I spent the last 35 years in healthcare. I've done every job from clinical care to respiratory therapy to EMT. I ran a billing company. I did sales in a billing company, and now run an auditing firm. And over the last probably 22 years, I've probably touched 500 pathology practices in the nation. You know, one way or another, I've done consulting with them. I've done their billing, or I work with them currently in Vachette. So that's given me some neat insights. And when it comes to billing and revenue cycle, you know, our team looks at 22 different billing companies right now. We've probably audited about 80 different billing companies, so we know what the trends that are taking place. These are some things you're going to take home. We're going to see consolidation. If you look around you in any industry, you see consolidation. We're seeing it in healthcare. It's important to have a 5- and 10-year plan. Know what you're going to do. Have a 1- and 3-year plan too. Know where you're going to go. Expect lower rates due to PAMA. We're going to get into this Protecting Access to Medicare Act, which is going to drive us to know our bottom lines and our margins. As for Part A contracts, if you're at a hospital-based group, this Part A contract is going to be very, very important. This might be your last one. With this consolidation, there's going to come a time when there might not be a Part A contract. Part A contracts we do see have a lot of shared metrics and a lot of shared revenue and value metrics. Think GMC and Chevy and Chrysler when the big budget hit in 2008. They came to all their suppliers and said, we want, you know, cost plus 5%. And we could literally get cost plus 5% in healthcare. If you look at some of the independent labs that used to make 20, 25%, their margin is now 4 or 5%. And what happens in any industry when you have a 1 or 2% margin? If you have change, that forces that industry to go out of business. It forces it to be done. No longer will you be allowed out of network. If we take a look at out of network thinking and what we see nationwide, one of the big issues is it's almost become politically incorrect to bill out of network. Well, we can't beat up those patients. We can't send that patient a bill. We can't make them feel bad. So this makes everyone make less money. Private payers are pushing it. Obama and Obamacare plans are pushing it. UHC's come on board with that. And then the last thing we're going to talk about is alternative payment models in MIPS. This is going to take place. They might push it back another 6 months. The CJR thing is the comprehensive joint replacement. That's taking place right now, and that's bundled payments. We think, oh no, this is not going to happen. You know, Medicare's already come out and said we got 30% of our payments bundled already. Well, you know, as pathologists in labs, we don't see this. In radiology, you don't see bundled payments. You might see it in the family practice sector, but most of those guys are already employed anyways. Consolidation. This marketplace is consolidating. Medicare's out of money, and we know state Medicaid programs are failing. We're running out of money. So what do you do when you can't pay your bills? It's not your fault, right? It's somebody else's fault. And that's what the government's doing. It's saying, well, we don't want to pay doctors less. We're going to pay the hospital less and let them tell the doctors that we don't have any money. And it's this whole consolidation of the industry. If you think about any industry, usually this is a big percentage of the market. There's usually 2 or 3 players along here and a couple oddballs here, some generalists. These guys are the big guys, and these are the specialists or the subspecialists. Kind of like our company. We're a subspecialty firm, right? We're not out here with KPMG or anything like that. We're a subspecialty revenue cycle management company that looks at this for pathologists and labs, radiologists, for small practices and smaller practices. We don't want to be Deloitte and Touche. They're out here on this line. We're in here. And if you look at what's going on in this industry compared to all other industries, you see it. Typically, you have some generalists and some specialists, and then we move our way down to not clicking. Usually it's in a market where there's very little regulation, okay? Healthcare insurance industry, very little regulation. Mature markets, At the beginning, how many HMOs were there in the Toledo market? There was 27 in the Toledo, Ohio market. Now there's 3. We're seeing that consolidation. The rule, it's called the rule of 3. And usually there's a 20 or 40% player and a couple other small players. And that thing in the middle, that's called the ditch. When you become the 4th player in the 3-player market, guess what? You're going out of business. You're not going to last. Your sports authority, okay, which just announced they're going out of business. Happened in all these other industries: pharmacy, commercial insurance, hospital. We're going to go through each one. So let's take a look here. Pharmacy world. It's Rite Aid, Walgreens, and who's the other one? CVS. Those are your big players, right? All those little small pharmacies were all eaten up. These are the big players now. Why? Because, well, they have some great economies of scale when it comes to purchasing. You know, they can buy 10,000 gallons of milk versus 1 gallon or 100 gallons of milk, so they get it a lot cheaper. The FTC is looking into some of this. Prescription drug market. We saw Pfizer and Allergan look at buying each other out. And why did they do this? It was the concept of corporate aversion. Corporate aversion is when Pfizer sells to Aggregate, who's actually in Ireland, and Ireland pays 13% tax, or Pfizer pays 36% tax. So they sell to these guys, and guess what? They're 20% more profitable overnight. They actually came out and regulated against this, but you're going to hear more about corporate aversion. They call it earnings stripping. Everybody heard of fiduciary duty rules? This is a new thing that the government's coming out with also, and this affects everybody, not just physicians. The government's going to look at your 401k and how it's managed, and they're going to say, we think we can do a better job. If you look at some socialist countries, this has already happened. And guess what the government's going to take your 401k and do? Guess where they're going to invest it? You guessed it. Government bonds. So they're telling you that you're not doing well, you're going to invest in us. This is not a good symbol coming forward. Hospitals. There's 5,724 hospitals in the United States, as Kyle's finding out. We know that 53% are in a system, and 13% are owned by a large corporation. We know that Tenet actually fell off the S&P 500, but there's still a lot of large corporations out there that own hospitals. Healthcare mergers and acquisitions is as big as it's ever been. Last year was numero uno. It was the big thing. Hospitals buying hospitals, hospitals buying physician groups, pharmacies rolling up, drug companies rolling up. We're seeing this consolidation in healthcare, right? And one of the things we look at is something called a super ACO. Imagine a model where there's 200 health systems in the United States. Maybe there's 3 in Michigan, maybe 3 Ohio, maybe Indiana has a couple. And then imagine the money trickling down from the federal government into these super health systems. And then those super health systems trickling that money down to their providers. Okay? And if you look at what's, for example, look at the Cleveland market. You got University Health Systems and you have Cleveland Clinic. Those are the big players. We're working with practices right now where there's 5 different pathology groups rolled up into one pathology group because there was 5 different hospitals and now they're one health system. We're going to see more of this. This is going to happen. And this super ACO model echoes what we see in any other national healthcare system. You know, in Canada, the provincial government gets their money from the federal government and they trickle it on down to their hospitals. Insurance companies. UHC, we know that they've got a couple interesting things going on. We see the Aetna Cigna, the Humana Cigna, all these things rolling up, right? This is classic consolidation. These are the big 3. This is it. You're going to have little guys left out there, but there's not going to be a lot. There are some states trying to fight these things because it means less money for providers, obviously. But the FTC hasn't jumped in and said no. The Federal Trade Commission says you can't have a monopoly, okay? But they haven't said you can't have a monopoly here yet. One of the concepts is, imagine a world out there where there's only one insurance plan. You don't think single-payer system is an issue, but imagine one of these guys being the single-payer intermediary for private insurance. It could very well happen. Physician group consolidation. It's double. In 2013, 44% were employed. 2014, it's up to 53%. Estimates now at 65% of all doctors are part of a health system. And it's going to continue to go that way. As we push into a bundle payment, it makes it easier. It makes it easier for those docs to get paid. Yet, we see a physician shortage, and they're talking about a big shortage of primary care. Well, what did Obamacare do? What was one of the #1 things it did? It gave money to primary care. It gave extra money to primary care. But did that motivate a bunch of docs to jump into primary care? No, it didn't. The issue with Obamacare is it offered access to health care, but it didn't offer payment to health care. All right, so all of a sudden I got free health care. I get to go to the doctor. You call the doctor, he says, I'll see you in 6 to 10 months. You don't have access, so what do? You go to the ER, you go to the urgent care. We really haven't changed anything. And with this shortage coming up, we're going to see longer wait times. We're going to see an increase of physician extenders, right? That has to happen. If you look at any national health care plan, a nationalized health care system, they have a lot of physician extenders. You go to see a pharmacist, he'll see you. And if your arm's actually falling off, then you get to see a family practice doc. And then 6 to 10 months later, you actually get it sewn on by an orthopedic surgeon. That's what we're looking at. We're looking at a devaluation of the quality of health care. And the truth is, we're out of money. So what do? When you run out of money, you don't eat pizza every meal. You end up eating DiGiorno's. I'm sure DiGiorno's will be upset about that. Billing companies have continued to roll up, and we know that's going to happen more and more and more. This is healthcare today. We have coverage. It's just not in the right place. Obamacare, let's talk about that. They're now measuring insurance plans by their size. So the bigger insurance plan is a better insurance plan. And they're rating, they're actually rating them by size too. So if you have more providers or more hospital in your insurance plan, it's going to be quote unquote a better plan. You can see this whole push towards bigger is better, right? And what happens when you have 10, 5, 3, and then we're going to have 1? And that's the thinking, is we have to consolidate. So we're going to consolidate. And by rating them by size, that makes your insurance plan be big. So if you're a little tiny Ed's insurance plan out there in Ottumwa, Iowa, you're going to get eaten up. It's going to happen. It's going to change. Surprise laws. Surprise laws will continue to be in effect. I know a couple different candidates are pushing against this. But this says basically if a referring physician doesn't check to see where that the referral he gave to another doctor, if that doctor doesn't have the same insurance plan, and you send the patient there, it's going to be your fault. So imagine, I'm a family practice guy, and I'm sending my guy with a bad knee to the orthopedic surgeon guy, but I got to check and see what insurance plans he has first to see if they'll take him? That's ridiculous. There's no way you can know. I will guarantee the orthopedic guy doesn't even know how many insurance plans he has. It doesn't work that way. It's very, very hard. Out-of-pocket expenses is only going to go up. $7,100. So imagine you're making $15 an hour and you're working your tail off, and you got Obamacare, and you come to find you got $7,100 payment on something. That's ridiculous. And these are going to go up. This number is going to go higher. So what are you going to do? You can do exactly like you did before. You're not going to see a doctor, or you're going to put it off. We didn't make it better. We just made it more expensive for the average Joe. We did drop the number of people who are quote unquote uninsured. So now they have insurance. They have some type of access. They still can't see a doctor, and they still can't afford to pay for it. One of the trends we're looking at now is tracking AR numbers without self-pay. We have to be able to look at that, because self-pay has become a no-pay number. We have to say, what's your AR over 120, and what is your AR over 120 without self-pay? Because we've created a system where there's a lot more self-pay patients who aren't going to pay us. Exchange plans. These are not going well. They're losing 25% of their volume. I read an article that says, well, people are leaving the exchange plans and getting insurance from other sources. Well, I beg to differ. There are no other sources. The other source is no insurance or through a company. And I know numerous business owners who are struggling to maintain their margin because their premiums have gone up 25% every year. It's very, very hard to maintain a margin if you're going to have to increase your cost 25% on a big ticket item. It's come out a couple times. They come out and said enrollment is at 21 million. Oh, well, we think enrollment might only be 12 million in these exchange plans. There's a lot of interesting articles out there about why they're losing so much money. $1.2 billion. We could have gave the patients this much money and paid them not to see healthcare providers. Why are they losing money? Well, let's take a look at Maine. The CEO and the COO were making about $300,000 in 2012. You know, a couple years later, they've basically doubled their salary, plus, and they lost $31 million. I want to run a company where I can make $700,000 and lose $31 million. And this isn't alone. This is Kentucky. This is California, Texas, Illinois. These are all over. Kentucky lost $145 million in like 8 months. Well, they say the exchange plans are failing. They say that people are sicker than we anticipated, and medical costs are higher. So we got to ask ourselves, who are people that are getting on the Obama plan? Well, a lot of these people were sick anyways, and they couldn't afford a full-time job or couldn't make a full-time job, so they got forced into this plan. This number here, this 22% higher, this is insurance plans saying we're not making enough money on these. And that's why people are bailing out of these programs left and right. UHC basically says we're not doing it anymore. A lot of people end up on state Medicaid programs, and they're growing. Why is that? Well, they went to the state Medicaid program, joined the Obamacare program, waited 3 months, dropped out, go back to the hospital because they need treatment. What does the hospital do? They sign them up to the best worst payer, which is probably Medicaid, the state program they know is going to get paid quicker. A lot of hospitals and health systems are worried about their exchange plans just going out of business. We saw this in Wayne County back in the late 90s. There was 9 different HMOs that covered Medicaid patients. That was the rule. Everyone had to be in there. And literally 24 months later, they're all out of business except for one, I think. And we got 3 cents on the dollar. A lot of our docs got paid nothing for all that work they provided. The Medicaid program is interesting because the federal government pays 57% of it. All right? So the federal government says, we want you in the exchange programs, we're going to give you a voucher, you know, we're going to pay 57%. But the states that didn't go in, they were saying, hold it. We're not sure this is going to work. We don't have money in the budget to do this. 19 states said, we don't think the vouchers will cover the cost. Echo this back into 3 years ago when everybody had to have an EHR at a hospital or healthcare system. So the government was giving $300,000 or $400,000, $500,000 to healthcare systems to put in EHRs. But they didn't give a penny to manage that EHR. So 3 years later, you got a piece of software that's never been upgraded, that needs work, and you got to spend 150 grand on people and upgrades to keep it going. So it's like giving somebody a burden. It's like giving them a debt. And these states said, no, we're not playing this game. And it turned out that they were pretty true. So UHC pulled out. A lot of them are pulling out right now. A lot of them say they're losing money. And we're watching the whole Obamacare Exchange program kind of condensed. There'll be a few players, right? Rule of consolidation, rule of 3. There might not even be 3 left, though. And they want to raise premiums. Medicaid. State Medicaid programs are failing. Illinois hasn't passed a budget since July of 2015. So if you're a provider in Illinois, guess what? You haven't been paid. From Medicaid, it just sits on your books. Louisiana came out and said, we're on the verge of imploding. This is what happens when you can't pay your debts. Oklahoma, they since reversed this, but at one time they were thinking about a 25% cut or even elimination of the total Medicaid program. We're just not going to have it. 800,000 people, sorry, we don't have the money, we're not going to do it. I think they since reversed it and said they're going to just do some cutbacks. What did Medi-Cal do, the California Medicaid? They had a 10% cut, and then they had a 10% retroactive tax on this. They came back and said, we want 10% of all the money we gave you back from last year. You cannot run a business, I don't care if you're making doorbells or ding-dongs, where someone comes out and wants 10% of their money back. You can't run a budget that way. Why would doctors become employed again? because they're tired of fighting this fight. So what are we going to see? We're probably going to end up with a tax. And it'll be called the Protecting Babies Who Need Health Care Act or something like that, right? It will. And everyone will pay it. Everyone will pay it. It won't be on the rich. It won't be on the people with 3 arms. It'll be everybody. And that's how it's going to happen. We're going to have a national health care tax to cover this stuff. That's the only way we can provide anything. And what does this do? Look at Europe, France, Sweden, 75, 78, 72% taxes, right? They have a national health care system. Basically, you see a pharmacist and you wait forever, but it's free, right? But their taxes are through the roof. And that's what we're creeping towards. That's how we get there. The Protecting Access to Medicare Act. Why is this unique? Well, it protects access to Medicare. But basically, for a pathologist or laboratory or provider, it does some interesting things. It tells you're going to have to report how much money you're being paid by different providers, or excuse me, different payers. So if you have 5 insurance plans and you get paid 140% down to 110%, you have to report to Medicare and tell them that. Well, what does Medicare pay? They pay 100%. So what is Medicare going to do? They built in a price decrease in this to say we can cut it. We can cut Medicare 5%, 10%, and then 10%. Because Medicare is going to say, listen, if a bunch of your plans are less than Medicare, 60 or 70% of Medicare, a lot of the national labs are doing work at that rate, why would Medicare pay 100% when everybody else is paying 60%? It's a race to the lowest common denominator. That's exactly what they're going to do. And this is unique because it has the price decrease built into the plan. This is the echo in the future. We're going to see more of this. It has to happen. We're out of money. And the commercial plans will follow suit. I guarantee it. MIPS. This is the merit-based incentive payment system. This is our new bundled payment system and where we're going with this. You have to be a qualifying provider, and you have an option to earn more money and get more or get penalized. But the whole key is it's budget neutral. And it's going to be based on regional stats. Regional stats get us to what? A population health management. Population health management gets us right into single payer system. The concept ties in well. You're exempt in your first year, starts 2017. Interesting thing about MIPS, 4 categories. We're going to go through each one of these. You're going to get points for each one of these things. So you start off with PQRS. We know that 61% of the practices failed in PQRS. There was a cure period. We're still seeing practices figuring things out. And the payment this year is tied to 2014. So you can live at 1.5% less Medicare, but can you live at 9% less? And you got to look at it as a business. Any business that's making 10% less or 9% less than its competition, that's 9% less money to hire quality employees or to do marketing and sales. You'll go out of business. It will force the bad businessmen out of business. It truly will. That 9% might be their margin. This is a value modifier. We're still waiting for some of this stuff to come out. This would be worth, it's at 100 groups, big groups right now. It'll come down to small groups. Anything's going to trickle on down. And it'll be a negative payment, and it's going to be coming out here fairly soon this summer. We take a look at the EHR. We talked about this a little bit earlier. I don't know how this is going to work for pathologists or laboratories. There'll be some interesting things there. 25 points for an EHR. Clinical practice improvement. This is a new category. This is how we're gonna measure your clinical practice and how well you do. If you take $112 to put stitches in, and another guy takes $110, he's better than you. And we got to get utilization down, right? So we start valuing everything and we start measuring everything to say you're ordering 24 stains on this, and this guy over here is only ordering 12 stains, so he's a better doctor. Now, do we talk about the value of the stains? Absolutely not. There is no cost about quality of healthcare in here. You get 15 points for this, and I think you get 7 points just for being an alternative payment model. So if your hospital has an ACO and you sign up, hey, you got some points already. Now, you probably haven't been paid by a hospital for your ACO. We have a couple hospital groups with ACO models that the hospital owes them a lot of money, and just not paying them? You know what they did? They came back and said, you know, we got to rerun those numbers. We're not sure that's right. That 600 grand is probably, that number's too big. Well, we know the numbers, and we know what the value is, and we know how much we're owed. But we're going to see a lot more of this coming forward. So if you have an ACO, get involved with it, get on the board, and expect some arguing. So we're going to score this stuff out. Each year it's based on a threshold. If you get a 55 and everyone else gets it, you know, and you end up, the threshold at 55, you get a 54, you get a little penalty. You might get a little bonus if you're above that. Again, the big thing is, remember, it's budget neutral. It's budget neutral. So they're going to have a fixed amount of money, and they're going to give some of it to the winners and nothing to the losers. If everyone goes up a little bit, guess what? Everyone's going to get a little tiny bonus. That's it. And it starts off at the individual practice, but it's going to go to the region. It's going to be a regional thing. Not an equal number of winners and losers. This is kind of an equation. You give us a call if you want more interest into this. But basically, you can end up with a 27% bonus or a 9% penalty. And I want to be in the 27% upside myself. That's just my thinking. You're going to compete with other people you know for the dollars. Final note, it's going to be out there so everyone can see it, and we're still waiting for more details. Let's take a look at the next thing up. This kind of lays it out. It's a little graph model that kind of lays out exactly how MIPS will play out. This is going to be updated because obviously, you know, these timelines will be pushed back, but it is coming. Again, we're out of money. Comprehensive joint replacement. This is interesting. Bundled payments. It's based on regional performance, and there's a limited number of incentives. So what's in a bundle? Now we're thinking right now we're doing below the hip replacement, ankle, knee replacements, both basically knee replacements. So the physician services is not actually in the bundle. They're still billed fee for service. We think that's going to end. We don't know when. But all these other things are built into the bundle. Okay, long-term care, skilled nursing facility, outpatient, clinical lab, DME, Part B drugs, and if your knee surgery goes really bad, hospice. Okay? And with the way healthcare is going in quality, that might not be a bad play. You might need hospice for your next knee surgery. Scary but true. Some rules. All the providers are required. The hospital, the acute hospital where the surgery is taking place, they're the risk-bearing entity. They're going to take that risk, and then they get to trickle it out. They can give up to 50% out of it, but you can't give more than 25% to one provider. So of all those lists, you can't give more than 25% to your piece of pie. And then some other rules here. It's set on a target price, and if you're below the target price where you showed value, you get your money. If you're above it, you didn't show value, you don't get any money. And if you're above it, you have to pay the hospital, you have to pay CMS with the difference. It's based on regional claims data. This is very interesting. This is where we get to population health management. So it starts off up here. You get 5% plus or minus. 1/3 of your metrics are from the region. Let's take Detroit. So 1/3 of it's from Detroit, and then 2/3 hospital specific. Next year, 2017, the same thing. Well, 2018, now we're going to plus or minus stopgap of 10%. You can make or lose 10%. But it's 2/3 every hospital in Detroit and 1/3 your hospital. And by 2019, it's every hospital in Detroit being measured on the same metric. So, if there's 2 or 3 bad players in here, no one gets money. This is regional healthcare. So what is this going to do? I have 12 hospitals all performing knee surgeries, right? Aren't they looking at joining up to be one hospital that joins a knee surgery? So they can control utilization, they control cost, they control all those people in that panel? Again, it drives us to that bigger healthcare system. It drives us to a single payer. This is very, very interesting that this came out as regional. You're going to get paid by a regional metric. Again, think about super ACOs and think about population health management. Think about those are the things that are going to take place. We're out of money. We have to pay everybody less, yet provide the same quality. We're not going to provide the same quality. It's not going to happen. So how can we provide everyone less without making everyone need medicine? That's the rule. Massachusetts, bigger is better, right? That's what people think. Interesting little study by the Health Policy Commission there. People like a big health system. People follow their primary care docs. So my primary care docs at one hospital, he gets bought by another hospital. Guess what? I'm going over there already. I knew this back in the 90s when I was working up in Detroit. I worked at a little hospital called Holy Cross. We had no orthopedics. We had no I can't even say the word. We didn't make babies there. We had no baby. We had no baby department. So we knew that that hospital wasn't going to last. We had a big psych unit. We had a little ER, but we knew that moms go where their baby's born, because baby follow-up visits at the hospital, pediatrics is at the hospital, orthopedics is at the hospital. Everything's there. You kind of go where the baby's born at. Your primary care docs. Why are all the hospitals buying these primary care docs? They're buying patient access. They get them all to go to the same place. Makes perfect sense. So we found out in this study found out in 2008, 62% of patients were associated with the 8 largest systems, and it went up to 76%. So the systems are consolidating. People are going there. They like it. It makes it really hard on the little guy. Well, what we talked about is the fact that community hospitals are going to struggle. We're going to have an issue with that. We know 53% of all hospitals are a system. I'd love to see that number in 5 years. It's probably going to be 65 or 70%. If you're geographically isolated, you might be able to stand alone because you could get some good reimbursement. But in a lot of places, you're going to struggle. There are very few independent urban hospitals. It just doesn't exist. Part A, value metrics. More risk sharing. Know your timing here. A lot of Part A contracts are coming with key performance indicators, KPIs. They're tied in there. They say, you're going to do this, and if you do this, this, and this, we're going to pay you more. A blood bank is very typical on this. Turnaround times for lab, those type of things. Risk sharing. We have some situations now where we tell the hospital, here's how much we want to make as a group. Let's say it's $300,000 per doctor. And anything more than that, we'll split with you 50-50. But anything less than that, you make us whole. This way, if the hospital forces us into a contract, guess what? They assume the risk. They might have to pay us more. And we're going to see more and more of that take place. And as for the timing, this might be the last Part A contract. We've heard that from a couple different practices already. So know it. Be aggressive. Try to get a 5-year contract if you can. HCA in Florida, they no longer have Part A contracts because they no longer have employed physicians. They're all salaried. True profit sharing, cost plus. Imagine if you could go to your group and say, or your administration and say, here's our cost to do this. We want 5% on top of that. That conversation could very well be happening. It could take place. Payor Building, interesting things here. Less out of network. The Obamacare came out and said, the Obama administration came out and said, we don't like out of network situations. We don't want patients balance billed. UHC had a huge issue in St. Louis where they came out and were arguing against some of their groups, some of our groups, in fact, saying, you're out of network. You're going to be punished for this. Making the attempt to bill. This is still an argument. It's still iffy. My thought is you have to make an attempt to bill. There's places out there that don't even bill out of network. They just let it slide. We talked about St. Louis a little bit. Professional rates are now being offered at the same rate as independent lab rates. So it used to be when we got a contract from a big payer that say pay 140%. Now they come in and say we want to pay you 60% because that's what we pay the big guys. And we try to argue, well, our value is different. We're hospital based. We're going to do some things differently. We're going to see 4,000 cases versus 16,000 cases. We're going to have our cell number on our business card. We're providing more value. So therefore, we need to be paid more. You have to have leverage to negotiate consolidation or contracts. And consolidation will mean lower rates. As these payers come together, Aetna and I think Anthem come together, they're not going to come out and offer you the best rate. They're going to look at the lowest rate and they're going to shove you into that. So you're going to have to renegotiate. And that means being aggressive. We spend a lot of time on the phone with insurance plans, first trying to get them to answer the phone, second trying to negotiate rates. We've had some very, very good success at this, and I've got some calls from my groups on that. Payor Building, aggregate payment rates. Again, you'll get a contract to say, we pay 136% of Medicare. Then you look at it by CPT code, and you come to find out your main CPT code's at 45% of Medicare, and something you do once a year, that's at 350% of Medicare. So it's an aggregate rate. It's a con. Any other way to call it, it would be foolish. And Indiana and Illinois, Medicaid, you can only look at an EOB electronically now. You can't look at a piece of paper. You have to dial in and look at it. And good luck trying to do that. Network arrangements. We used to say these networks, like Three Rivers and America's PPO, these were kind of bad because they're hard to work through. But we're finding now these guys are paying pretty darn good. And a lot of times, it's a good shift to kind of shift some of your work into them because they're paying 80% of charge still. And this means looking at your business and understanding your business. And the truth is, God bless them, most practices don't have these numbers. And they don't look at it and they don't figure it out. We're lucky, our team does this. Insurance out of network. And the Aero Network is very similar to, we saw some of the things earlier in the 90s on this. The Aero Network says you can only go to these providers. It's like a PPO, down to an HMO, down to an MSO, who knows what they're going to call it next, But what we're doing is we're limiting our exposure. We're saying you can only see these doctors because we're paying them very little amount of money, and we only want you to see them. That's the rule. Take a look at HCR Molina. Molina is a kind of a Medicaid product, and right now HCR is suing them for $88 million for not paying ER visits. Well, what happens when you don't have insurance? You go to the ER, right? Well, Molina says, well, we're not paying these. You know, in the ER world, it's very typical to downcode a case. You'll come in with a level 3, which might be a fractured leg, and they'll come back and say, no, it's a hairline fracture, so it's only level 2. And it's all based on medical decision making, and they argue your medical decision making. Again, the Obama administration wants nobody out of network. Balanced billing legislation. This is Florida's Congress, HB 221. This basically says if you're out of network, you can't balance bill the patient. So guess what? They can pay you whatever they want. They're a reasonable customer, whatever number they want. It could be 35% of Medicare, and there's nothing you can do about it because you don't have any leverage to bill the patient to get the patient to complain to the employer, to get the employer to complain to the insurance plan to come back and give you payment. Very interesting. This is put together one of our team members. There's 13 states that have these regulations, and it's going to continue to happen. Look for more legislation like this because it's politically incorrect to bill somebody for something you actually provided. What we're saying is that you should have free health care, and you shouldn't even have to pay that copay or deductible. Well, didn't we have a physician shortage? Do you think that's going to make that get bigger or smaller? I think it's going the other way. So let's take a look. We got the Obama plan saying no out of network. We got UHC saying, well, no out of network. We don't want that. We got Florida and Arizona saying you can't balance bill an HMO if you're out of network. You can't balance bill these people. You got Florida House bill that just came out and said, nope, can't balance bill anybody. Boom, you're done. So the CMS rate says, well, it's out of network, huh? 40%. That seems like, if I'm the guy at CMS, I'm thinking, that seems like a good rate. I see that for some other people. Oh, let's look at PAMA. Let's look at some actual vouchers. The vouchers come in at 40% of Medicare. So the guy over here at the head of Medicare says, wow, we're paying 100%, and these guys are paying 40%. Maybe we should do that. So what does PAMA have? It has a decrease built into it, locked in. So what does CMS do? They drop the rate to 40%. So what does this do? This forces providers to be very good businessmen or to look somewhere else for their business. And that's why we're seeing consolidation of healthcare. That's why we see M&A in the healthcare industry through the roof. Because docs are looking at this and they're going, holy crap, how am I going to do this? And it's not just pathologists, radiologists, it's everybody across the board. So again, things to take home. Consolidation, be active, be aggressive. We've talked about some of these things, but let's talk about one more thing. Let's talk about the Lake George Grocery. I'm from this little town in northern Michigan, and I got to visit this place not too long ago. 250 people, 2 grocery stores. They're both barely hanging on. Dollar store opens up across the street. Right? Dollar buys milk for, they buy tons of milk. They buy all their sweets really, really cheap. Huge buying power. What does Lake George Grocery do? Do they fold up their shop and go home? They go to business? No. They put in a fryer and they start making food because there's no restaurant in Lake George unless you go to the bar. So what did? They kept their feet moving. They became good businessmen. They're trying to carve out that margin. And that's what we're going to see as we look forward in the industry. We're going to see practices be good businessmen, and being aggressive, and know their margin, know how much they're making. I asked them, I was talking to them, how much did you make on these potato chips you cook up here? Or they made me they call them funnel cake fries, really good. In fact, I think my arteries are still clogged. But great stuff. But it's a great idea, right? They kept in business. And as businessmen, we have to do the same thing. We have to be aggressive, and we have to go forward that way. Thank you very much for your time.